Good morning. Thank you everyone for coming to this session. Sir has laid the background so well that it makes my job easy. We know of all the models, so I will not spend too much time in presenting this, except to say that diabetic retinopathy screening is currently mostly opportunistic, and what we need to do is to scale it up to something that can be systematically done for our patients with diabetes. As Sir said, we would like to integrate at all levels of care and go all the way from promotion to rehabilitation if this has to be successful. The heterogeneity in the healthcare seeking pattern in our country is very, very difficult and challenging. It could be just a pharmacist or a government sector physician or a fancy polyclinic physician who would be taking care of the diabetes, so one size does not fit all. So what are we saying here? There are multiple stakeholders in the care of a person with diabetes. Just like Sir said, physicians would be the best to do the screening, but we will have to hold the hand of at least one physician so that we make this possible. Who are the other stakeholders? We will see as I go on with the talk. There are about 23,000 ophthalmologists as of 2021. If each of us partnered with at least one physician, and the physician has, say, a database of 3,500 patients that he or she is looking after, it may be a doable task. In contrast to the 23,000 ophthalmologists, there are about 1 lakh and plus physicians on board. The task is very daunting because more than 50% is undiagnosed. In a good scenario, unscreened maybe 30%, and even in the best scenario, only 10% return for their systematic screening. A standalone physician struggles. We saw that there's not even a vision chart. He may be really aware of the systemic control, but the deterrents become the cost of equipment, having extra personnel, not knowing what to do with the patients they screen and find, lack of awareness and lack of interest. However, if the ophthalmologist, with their resources, which includes the optometrist, physicians who could do the laser injections and the vitreoretinal surgery, partners with one physician and his ecosystem, his or her ecosystem of one lab technician, a pharmacist, and a nurse educator, either by direct visualization of the fundus or a fundus image, it should be possible to screen all the patients that go through the physician's clinic. We would definitely be stronger together. The advantages this presents is the patient is not going to come to the ophthalmologist unless he's either referred or symptomatic, which is very late. One database for follow-up can be set up in this system. There's partnership and harnessing of resources from both sides. There's awareness building, and the personnel can be shared. Patient anyway comes for systematic care of diabetes. Systematic screening for DR then becomes a part of it. And it's crucial to complete the loop to say whoever was screened, has they been referred and treated and come back for rescreening. It definitely provides an opportunity for diabetes support groups. So who should screen? We say that it's ideal to do it at the physician's clinic, but any of the possibilities can be considered if this partnership is considered. We'll go through that one by one. But remember that the patient is at the center of this. So it depends on what the patient is likely to use and is comfortable doing. We need a diabetic registry to start with, to say that these are the patients I'm going to look after in the next year, which should include details about screening, outcome, referral, and treatment completion. There have been various non-doctor things that have been tried, and there's a very good publication by Dr. Das and his team. A lab technician does 3 monthly HbA1cs. If he could just be reskilled in that office to take a fundus image, which can either be AI'd or reported simultaneously, it should take us to the next level. A pharmacist-led screening has been very acceptable. Standalone pharmacies have a problem of space, but one in a practice where the pharmacist is free at other times could be another model where you could incorporate it in the physician's practice itself. You could also have an optometrist stationed in the physician's clinic if that was possible. Either the optometrist is employed by the ophthalmologist or the physician, that is immaterial. A nurse educator has become standard of care in most diabetic clinics, and this person could also be skilled to do the screening. In a study where they were training NCD nurses alongside the program, 75% coverage was attained in their group of patients. We have a couple of very strong studies which have partnered with the public health system in India. We have seen very good improvement in persons being screened and treated. The catch, of course, was that 10% only returned for annual screening. Nayanamritam study, you will hear of more from Dr. Shobha when she comes up, but that has been a successful model, and I hear that Kerala has adopted it as a policy which needs to be taken to the rest of the country. And how do we want to do this? If it's a tertiary care or a polyclinic setup where an ophthalmologist is part of the system, you could even do direct visualization of the fundus. However, if it is a standalone physician, there is a possibility of doing the camera either with the AI or with somebody reporting the images. We are all aware of the advantages and disadvantages of both these systems, and most of us use the international classification, and referable retinopathy is moderate and above, or diabetic macular edema. We have to remember that the patient has to be made aware. A patient-held card with health education on it, the status of retinopathy, and the next follow-up visit is mandatory, because this is the link between the ophthalmologist and the physician, and the patient takes charge of his or her own eye. This has now been a bottleneck, as mentioned by Sir as well, that there are not as many treating physicians who can take care of the lasers, the injections, and the vitreoretinal surgery. This will have to be handled and identified by the ophthalmologist before starting this hub and spoke model. It is nice to hear that PMJ has actually also recognized this, that the cross-specialty model with reimbursement being applicable both to screening by a physician and an ophthalmologist at least has been made available. So what do we need to do this to strengthen this pathway? WHO has laid out the map, and the steps are very easy. You identify one physician practice, get your diabetic database, inform and invite all the eligible diabetics in that practice, choose the modality by which you would like to screen and who should be doing the screening, giving adequate training, and as a first thing, report the screen negatives, which means the non-referable retinopathies, so that they come back for their systematic screening. With the positives, we need to identify the diagnosis by the ophthalmologist who's partnering, and then the intervention is done by the partnering vitreoretinal surgeon or the medical retina person. Most importantly, keep an eye on the outcomes and report them for yourself so that you know that the system is working. For example, we have an endocrinologist who works in Vellore. His practice has about 3,500 diabetics under his care. He's partnered with an ophthalmology setup where they come weekly and do the screenings. So this would be in a private care facility. His trained nurse educator can take the fundus images. The referral threshold was as we had mentioned. The patients are then referred to the ophthalmologist he's partnering with to do the examinations, and then treated by the VR surgeons in their clinic. This is monitored as an outcome, and this continues as a cycle. This then becomes the hub and spoke for those 3,500 patients who will hopefully get systematic screening. We should remember that ultimately change is only going to happen if the patient takes charge that they need to be screened. At every point of contact, patient education has to be primary, and these are some of the points that we need to remember when we design this. What do we do at CMC? We are very fortunate to have all levels of care within the umbrella of an institution. Primary care is done both by community-based grassroots level workers and vision centers. At the secondary level, we have integrated vision centers, which are part of the secondary hospital. And for the tertiary and the quaternary care, we do direct examination by ophthalmologists, which are part of the clinics. In the primary setup, it is by fundus imaging and reporting. We have trained our grassroots level workers for perceived visual disability. This also includes public health nurses who have been trained. And we have a unique program where there's a Makkalai Thedi Maruthuvam, which are grassroots level workers who go house to deliver medications. So these are our foot soldiers to bring in the patients to the physician clinic. We also go alongside the mobile clinic, which runs in the villages, which is run by physicians, and we do our screening alongside. This is how the cycle goes, and those who are referred are then sent for laser. In the secondary hospital, it is either done directly or in the integrated vision centers, which I just mentioned. Our study showed us that there was lower prevalence in these clinics of VTDR and blindness. Referral uptake was a problem, so we added on a mobile laser clinic, which goes once in 2 weeks. Tertiary care screening and quaternary care screening, as I mentioned, are done by senior ophthalmologists. We don't forget rehabilitation, because that is also a part of the continuum of care. And please remember that we have to capture the outcomes at each level of care, not to forget proportion returning for systematic screening. If we save the money in doing unnecessary screenings for those who do not need non-referables, we can use that amount to screen the others better. So what can each one of us do? The charge here is that each one of us in India as an ophthalmologist should partner with at least one physician, create a referral pathway, use the tools by the WHO, and close the loop. Empower your patient to seek screening for diabetic retinopathy. Dr. Honavar had written an editorial which said, widen the net, tighten the mesh, one space at a time, one ophthalmologist, one physician at a time. Prevention prevents 90% of vision loss, and that is the need of the hour. Thank you.
Thank you so much, Dr. Padma, for that insightful